Okay. Anybody who wants to read it, or
A
should I?
20,
Yeah.
yeah, 28 years old woman, gravida 1, para 0, at 35-week gestation, presents to her obstetrician office for a routine prenatal checkup. Fetal movements is normal. Pregnancy has been uncomplicated. The patient has no chronic medical conditions and has had no surgeries. The prior visit at 33-week gestation demonstrated a breech presentation. A repeat ultrasonogram today shows persistent frank breech presentation. No fetal or uterine abnormalities are noted. She has intact membranes. Examination shows a closed cervix. Fetal heart monitoring is reassuring. Which of the following is the most appropriate next step in the management? A. Attempt external cervical version. B. Attempt internal cephalic version. C. Routine checkup. D. Discuss cesarean section with the patient. E. Discuss vaginal delivery with the patient.
So a lot of you have been writing C, and some wrote D. Anybody who has a different opinion? Okay. So it says 28 and 35-week gestation. Okay. So many of you wrote C, so let's go with the C. So the answer is routine follow-up. So this is basically breech presentation occurs when the buttock or the lower extremities of the fetus presents first in the maternal pelvis. The majority of the breech presentation with the self-correct by the 37 week of gestation. Therefore, any attempt to convert breech into vertex is not indicated before the 37-week. Routine follow-up is the best option. So this is very nicely written, the types. Okay. So the breech presentation diagnosed before the 37 week of gestation does not require any intervention or any breech presentation, often convert to vertex before the 37 week, and external cephalic version is indicated if the breech presentation is persistent after 37 weeks. Now moving on to the next one. So this one, anybody who wants to read it? So this is the question of the following. The same question, this one, the part A, since says related question, right? So this is the part B. Okay.
Okay. 2 weeks later, the fetal head is palpated by the obstetrician in the upper abdomen with leopard maneuvers, Leopold maneuvers, and following ultrasound confirmed breech presentation. A biophysical profile of the fetus is performed with a reactive non-stress test and an overall score of 10 by 10. Which of the following is the best next step in management? A. Elective cesarean section. B. Emergent cesarean delivery. C. Apply forceps now. D. Induction of labor with intravaginal prostaglandin E2 for a vaginal delivery. E. Offer the patient an external cephalic version.
Okay. So everyone is writing E. Anybody who has a different opinion? No? Okay. So let's do E. The answer is E. So external cephalic version is basically a maneuver performed via external abdomen, sorry, maternal abdomen to convert from the breech to cephalic version. So external has been given to the significant reduces the attendant risk of the both vaginal and the cesarean section. So cannot be performed once labor is initiated. So remember this, without adequate amniotic fluid, okay? Fetal heart racing are non-reassuring. So these are the things that you have to see. The risk of performing includes the abruption, cord prolapse, so and may require emergency cesarean section. So moving on to the next one, anybody who wants to read out aloud, this is a co-worker thing. It's from the ethics. Not ethics, actually, infectious diseases. Anybody who wants to read it? Hello? Anybody who wants to read it aloud for everyone?
Yeah, I'll go ahead.
Sure. Go ahead.
A coworker is taking care of a patient in the emergency department who has HIV with a CD4 count of less than 100 and a high viral load. After a large bore IV is placed, the coworker is cleaning up the sharps when she is stuck by the bloody 16 gauge needle. The skin is broken and with an obvious puncture wound. The coworker requests post-exposure prophylaxis. What is the most appropriate regimen? Nevirapine and tenofovir, emtricitabine. B, efavirenz and tenofovir, emtricitabine. C, raltegravir and tenofovir, emtricitabine. D, abacavir and tenofovir, emtricitabine.
So many of you, is it a C or is it E? Anybody who has a different opinion? Many wrote E. No, not E. I can't decide where the next question is starting from. So I don't know. Is it the C or is it the E one? Has anybody given the opinion of E as well? E. Okay. So I'm going with A. Okay. Okay. So a lot of people have given the option of C. So the answer is C. So this is this. So it says the risk factors of the healthcare personnel of
Assalamualaikum.
contracting HIV from the exposure to the
क्या हाल है बजी? ठीक, अल्लाह का शुक्र। आप सुनाएं?
Okay, so this is basically a needle stick injury is about 3 per 1,000 in non-prophylaxis. The first response to the percutaneous exposure should be the wash the area through the soap and waters for the punctures and the small laceration. So cleaning the area with alcohol-based hand hygiene agent is responsible. Exposed mucous membrane should be irrigated copiously with the water and saline. So this is all, everything is written. A source of infection with the negative and the positive, both are given baseline testing and follow-up. If this is positive, then the source of the HIV positive regardless of viral load. So this is everything. PEP, which one are given? Tenofovir, disoproxil, fumarate, emtricitabine. Okay. So if along with that, as early as possible after exposure, you have to start the prophylaxis. It is recommended that the PEP by continued for the 4 weeks. So this is very nicely written HIV. So you can see it from here. So this is it. So anybody who wants to read it, this one? Kindly make it quick so we can do a lot of it. Otherwise, we won't be able
I can
to.
read.
Okay, go ahead.
A 64-year-old male who has been a patient for several years present to your office with a complaint of 2 episodes of bloody urine over the past 24 years. He denies any flank pain, dysuria, fever, or chills. His urine stream is strong. He is able to void completely, and he denies to need to start or stop or strain during urination. Past medical history is significant for hyperlipidemia, hypotension, diabetes, glaucoma, and osteoarthritis. He has smoked 1 pack of cigarettes per day for the past 35 to 40 years. Physical examination reveals no costovertebral angle or suprapubic tenderness. Prostate examination revealed non-tender, non-enlarged prostate. Urine analysis shows gross hematuria without proteinuria, pyuria, or red blood cell cast. Creatinine is 98. Urine culture is negative. What is the appropriate next step in managing this patient?
Anybody who has any opinion about this one? CT, urography, ultrasound, biopsy, and PSA or prostate biopsy. So 3 of you wrote A. So let's go with the A. So somebody wrote B as well. Okay. So let's go with the most chosen answer. So the answer is CT urography. So the patient has a hematuria, and whether it be gross or microscopic demands further workup. Infection has been ruled out by the fact that casts are not seen. The glomerular cause has been ruled out. The patient has a high risk of urinary tract malignancy, like maybe renal, bladder, or prostate in the light of a gross hematuria, age more than 40. So these are the risk factors. Male gender and smoking history. So include history of the pelvic radiation or exposure of alanine dyes. So gross hematuria in such patients require assessment. To evaluate the genitourinary tract, one must perform urine cytology, cystoscopy, and CT urography. So this is it. So whoever chose B is basically ultrasound of the patient will evaluate the kidney relatively well, but miss small tumors. Okay. So moving on to the next one. Anybody who wants to read it?
I can read it.
Yeah, I will. Yeah.
Okay.
A 28-year-old man calls the office to ask for advice about fever. He has a mild cough for the last 2 days and developed fever and chills today with a home temperature of 38.7. Several of his co-workers have been sick recently. The patient's past medical history is significant for a motorcycle accident requiring splenectomy at age 22. All his vaccinations, including influenza and pneumococcal vaccines, are up to date. He was given a prescription of amoxicillin clavulanate 6 months ago, just in case. Which of the following is the best advice for this patient? A, take the amoxiclav now and follow body temperature for 24 hours. B is take the amoxicillin clavulanate now and go to an urgent care facility. C is take a new prescription for oral penicillin and come to the office tomorrow for evaluation. D is take acetaminophen now and come to the office if fever returns. E is take acetaminophen now and come to the office tomorrow for evaluation.
So anybody who has opinion about this one? A. Anybody else? It's okay if it's wrong. Just try writing it down so we can see it. Why is it wrong, right? So it's okay. Just give your opinion, whatever you feel like. So, at least you have an opinion, right? So give your opinion. Just be confident whatever you are choosing, okay? So A, C, A. So some wrote D as well. Okay. So should I go with A? Let's see. Okay. So the answer is B. Take now and go to urgent care facility. Okay. Why? So the ACE clinic patient. First thing, ACE clinic at an increased risk of infection. With which one? Strep, Haemophilus influenza, and Neisseria meningitis. So overwhelming infection is ACE clinic patient is rare, but rapidly fatal, but not if not recognized and treated aggressively at early stage. That's why they said go to urgent care facility. So on the presentation of the patient may have a mild symptom, non-appear toxic, but the infection will progress within hours to fulminant disease with a severe shock, sepsis, and disseminated intravascular coagulation. So it says it can be progressed to the severe ones. So any febrile illness in an ACE clinic patient should prompt aggressive antibiotic therapy. Even if the patient appears relatively stable, acceptable empiric oral regime include amoxicillin clavulanate and ciprofloxacin or extended spectrum fluoroquinolones. So this is it. Why A is not the answer or C is not the answer. Treatment should continue for at least 72 hours, okay? While urgent diagnostic evaluation like blood culture, radiograph is performed, patient with the signs of the severe illness should receive empiric broad spectrum antibiotics such as combination of vancomycin and ceftriaxone. Anybody who wants to read it? Nobody wants to read it?
I can do it.
Okay.
34-year-old woman comes to a new primary care provider due to diffuse abdominal pain and poor appetite. She has difficulty describing the pain in detail and cannot identify any precipitants. Nothing appears to bring relief. Over the past several years, the patient has seen 4 different physicians and has several hospitalizations for similar symptoms. Previous workups, including endoscopic studies and an exploratory laparotomy, have revealed no etiology for the pain. Recent abdominal CT scan and abdominal ultrasound were normal. Physical examination and laboratory tests, including comprehensive metabolic panel, complete blood count, and urine analysis, are within normal limits. In addition to explaining that serious illness has been ruled out, which of the following is the most appropriate next step in the management of this patient? A. Explanation that symptoms are most likely stress-related. B. Regularly scheduled office visits. C. Psychiatric consultation. D. Supportive psychotherapy. E. Symptom-driven follow-up as needed.
Yeah. So many of you writing B and one of you wrote C. So let's go with the B. Okay. Since I'm going with the most one, okay. Let's see. So the answer is regularly schedule office visits. The patient preoccupied with the medically explained gastrointestinal symptoms and excessive healthcare use are characterized of the somatic symptom disorder. The best approach is for the because then he needs a CBT or something like that. So primary care physician to reassure the patient. So starting with the reassurance that serious illness has been ruled out and the scheduled regular visits like every 2 to 4 weeks. So starting from the regular visits, then if the patient doesn't follow up or doesn't understand, then you are going to send to the psychiatry to develop the patient physician relationship. Okay, why this regular follow visit? To develop the relationship, monitor her condition, avoid unnecessary diagnostic testing, and specialist referral. So all of this, okay? It's very nicely written why you need the regular visits, okay? Physicians should treat symptoms conservatively and focus on the patient's functioning and strategies, educating the patient about the impact of the psychosocial stressors on the somatic symptoms and promoting stress reduction and the behavior. So starting if the patient regular follow-up and the patient education, antidepressant may be likely cost beneficial and maybe alone or in the CBT. So this one very nicely, somatic symptom disorder, a very nice table to understand somatic symptom. So one or more somatic symptoms, more than 6, disproportionality thoughts about the seriousness of the symptoms, high anxiety, excessive time and energy, headache, pain. So any of the symptoms can present back pain, pelvic pain, shortness of breath, vomiting, dysphagia, sexual. Starting with the schedule, regular visit, limit unnecessary workup, referral to specialist, reassurance, and then you are going to reduce the stress, improving coping strategies, and then the mental health referral once the physician-patient relationship is well established. So moving on to the next one, anybody who wants to read it? Anybody wants to read it kindly?
I will. A 45-year-old woman comes in with dysphagia over several years. The dysphagia has been mild and not severe enough to result in weight loss. She also complains of weakness and fatigue. Her blood pressure is 120/80 milligram mercury, pulse is 110, respiratory rate is 12 per minute, temperature 37 degrees centigrade. On physical examination, she appears pale, her tongue is swollen and red, and her fingernails are spoon-shaped. Laboratory tests reveal hemoglobin 99 grams, hematocrit 29%. She smoked cigarettes for about 10 years, but quit 10 years ago. Barium swallow demonstrates a web in the proximal esophagus in the post-cricoid area. Which of the following is the best initial therapy? A. Iron replacement. B. Pneumatic dilation. C. Surgical resection. D. Proton pump inhibitors. E. Diltiazem.
So they're very nicely explained. Web, okay? Tongue is this, fingers are this, smoke, 45, dysphagia. So very nicely written. So many of you have been choosing A. Yes, it's a Plummer Wilson. But what is the treatment? Many of you are choosing A. So let's choose A. So the answer is iron replacement. The patient is basically with the dysphagia to solid food, anemia, and the esophageal web. So giving you the Plummer Wilson. Okay, it's a Wilson V. Most patients with this condition are the middle-aged women, and the dysphagia is also limited to solid and a progressive over the years. The patients also have the symptomatic anemia. And additionally, patients have glossitis, chylomicronemia, so all of these conditions, then uncertain, autonomic, and 10% of the patients may develop squamous cell cancer. So the treatment is iron and then pneumatic dilation. Treatment for this one here. So moving on to the next one. Anybody who wants to give it a try?
I can read.
Okay.
A 22-year-old woman presents with difficulty sleeping, inability to concentrate, and increased anxiety for the past 10 months after she was sexually assaulted by a family friend. She has recurrent nightmares about the event, and her vivid memories have interfered with her current intimacy with her partner. She is easily startled and admits that he jumps at the slightest noise. She is tearful and states that she does not want to go on living like this. Which of the following is the most appropriate next step in the management? A. Begin psychotherapy to explore her relations with the opposite gender. B. Assess risk of committing suicide. C. Encourage the patient to join a support group. D. Explain this is normal behavior and send her home. E. Prescribe lithium for her psychiatric symptoms.
So we have discussed this in the class of psychiatry. What should be assessed? Okay. So many of you chosen B. So let's see, assessing for the risk of committing suicide. So the answer is committing suicide. So prevention is more important than treatment. So the patient is described hypervigilance and vivid recollection and cognitive difficulties persistent for more than 1 month, meeting the diagnostic and statistical manual of the mental disorder, the 5 additional like DSM criteria of the PTSD. Her mention of the hopelessness and suicidal ideation requires the physician to view the life-threatening condition. Suicidality risk must be assessed. So the patient high risk of the committing suicide and often have a developed active plan. So you have to rule out that one. So okay, these ones. So anybody who wants to read this one?
I can do it.
Okay, go ahead.
A 67-year-old man presents with right knee pain. He stepped wrong and felt a pop in his knee. On exam, his patella is inferiorly displaced. He is tender superior to the patella and is unable to extend his leg at the knee. His lateral knee X-ray is shown below. What is the most likely diagnosis? A. Osteoarthritis. B. Patellar fracture. C. Patellar tendon rupture. D. Quadriceps tendon rupture.
So a lot of you have been writing D. One wrote C. So many of you have been choosing D. So let's go with the D and C. Okay. So this is the answer. He cannot extend his leg. Okay. So that is one of the very important things. The patient is suffering from the quadriceps tendon rupture. There are 3 ways to damage the extensor mechanism of the knee: patellar fracture, patellar tendon rupture, or quadriceps tendon rupture. The classic finding is basically inability to extend the knee. Okay. So the classic finding is this: inferior patellar displacement and indentation superior to the patella, and the tenderness superior to the patella. So quadriceps is more common in individuals over 40 years of age with the systemic comorbidities, and the patient then at the risk of the underlying tendon weakness. So more common, these ones here. This is how it looks like. So kindly just see it. I'm going to zoom it in for you so you guys can take a look into this. How is it? This is the line going above at this level and going below. So low link patella, high riding patella, patella alta and patella baja. Less than 40, more than 40. So less than 40 would be patellar tendon rupture. This is normal, and then tendon rupture. Okay, quadriceps tendon rupture. Okay, so now move on to the next one. 23. Anybody who wants to read this? This is basically has 2 questions, part A and part B. Anybody who wants to read both of them? Anybody?
Yeah, I will.
Okay, go ahead.
A 63-year-old man is brought to the physician for evaluation of his behavior. His family states that recently he has been yelling, spitting, and pulling other people's noses and ears unexpectedly. He was always a fine man and devoted husband, but now uses foul language and is openly promiscuous. He has no significant medical or psychiatric history. The family recalls that patient's uncle displayed similar behavior and was placed in a nursing home, where he quickly died. On examination, memory and visuospatial functions are intact, but the patient exhibits some word-finding difficulties. During the examination, the patient keeps repeating the doctor's command and giggling inappropriately and loudly. Which of the following is the most likely diagnosis?
So Alzheimer, dementia, multi-infarct dementia, neurosyphilis, Pick disease. So a lot of have you been writing E? Should I go with E?
Yeah, the inappropriate behavior.
Okay. Basically frontotemporal. The other name of Pick disease is frontotemporal. Okay. Just giving you a hint. So this is Pick disease. So this is the frontotemporal dementia. The other name of Pick disease is frontotemporal dementia. So knowing about the personality and behavior, the wife will come and say, my husband is not behaving the same he was before. Something like coming to the behavior point of view. So it is more common in the men, especially those with an affected first degree relative. In an early stage, it is more common as personality and the behavior, such as disinhibition, impulsivity, and repetitive behaviors, hypersexuality, and hyperorality. So the treatment relies on the behavior management. So this is Moving on to the next one.
Speaking with the patient, you notice dysarthria. The patient most likely has a condition involving which of the following? A. Substantia nigra, B. Frontal cortex, C. Nucleus caudatus, D. Parietal cortex, E. Hippocampus.
So with the name, you can think what it could be. Okay. So this is the most likely has a condition involved. So somebody chose A, some chose B. Let's go with the B. So the answer is frontal. The name is frontotemporal, right? So the area involved would be frontal, right? Try to think of that way. Destruction of the frontal lobes. The frontal lobes include the Broca's area, like the speech area, frontal eyelids, and the prefrontal cortex. The lesion of the prefrontal cortex involves the inappropriate behavior, impaired judgment, and the lost behavior solving skills. Incontinence and gait may be seen, but it is not with this one. Okay, so this thing here. Okay, so moving on to the 25. Anybody who wants to read this one? Anybody is interested?
Yeah, I can read it.
Go ahead.
A 28-year-old tennis player presents the follow-up after a routine physical during which she was found to have 7 RBC per high-power field on a screening urinalysis. The urinalysis was negative for leukocytes, nitrites, epithelial cells, and ketones. The patient denies any complaints and the review of systems is essentially negative. Her last menstrual period was 2 weeks ago. What would be your initial approach in the workup of the patient with asymptomatic microscopic hematuria?
So order urine culture, CT scan with or without contrast, ultrasound, observation and reassurance of the patient as an asymptomatic, and repeat urine analysis in 4 weeks. So anybody has
Repeat in 4 weeks.
Okay. Anybody else? So some rows said E, some said D, E. Any other opinion?
Anything more than 2 RBCs in urine is abnormal. So this is 7. So you'll have to repeat it. And it could be secondary to her playing, right? Severe exercise.
Yep, it could be. So let's go with E. A lot of you chose E. So repeat. The microscopic hematuria is defined as 3 or more RBCs per power high field as a urine sedimentation properly collected urine analysis. Microscopic identified as the woman during her menses in a patient shortly after vigorous exercises or acute trauma can be confirmed by repeating the urine analysis. In menstruating women, the urine analysis should be repeated later in the cycle once the bleeding has been ceased. If this is possible, the tampon can be inserted and the urine analysis can be obtained and the perineum is cleaned. If patient who has hematuria identified in the setting of the vigorous exercise, the urine analysis should be repeated approximately 4 to 6 weeks later during the period of one exercise. The patient with acute trauma and microscopic hematuria should have a confirmatory urine analysis after 6 weeks. So this is okay. Who wants to read this one? So why not D? Okay. Why not D is microscopic hematuria is usually an incidental finding, but deserves a thorough workup as 10% can be due to malignancy. So you cannot just let the patient be as it is, okay? So anybody who wants to read this one?
A 77-year-old woman was admitted from home because of syncope. Her daughter reports that the patient has been losing weight and rarely eating since the death of her husband about 1 year ago. In addition, the daughter states that her mother's urine has a dark color to it and that she is very concerned. Her lab results are creatinine is 247, albumin is 21, and urine analysis shows blood positive. Urine microscopy shows 0 to 2 WBCs and 0 to 2 RBC. The patient does not have a significant cardiac history, but she has diabetes, takes metformin 1000 twice a day. What is the best next step in determining the etiology of her acute kidney injury? Creatinine kinase level, renal ultrasound, CT scan with IV contrast, glycated hemoglobin, LDH.
Okay, So somebody said A, some said B. So kindly write down as much answers as you can. It's totally okay if you're getting it wrong. At least you have an opinion, right? Having opinion is more common or more important than like, you know. Okay, so many said B, some said A. Anybody else who has a different opinion? A, B. Anyone else? Okay, so I'm going with the most ones. So a lot of said B, not sorry, B here. Okay, let's go with the B. So the answer is creatine kinase level. Remember non-invasive first, then invasive ones. Then coming to the patient is suffering from the acute kidney injury due to the pigment nephropathy from the rhabdomyolysis. So a urine dipstick test for the blood with the positive finding and the absence of the RBCs indicate myoglobinuria. So that's why they do CK level should be 5. The reference includes the rhabdomyolysis. So doing ultrasound is not going to give much of the difference. So imaging studies in the rhabdomyolysis may indicate the muscle edema or the hemorrhage. So several studies show that the benefit of ultrasound in the diagnosis of rhabdomyolysis. However, most consistent data is needed to rely on the diagnostic tool. Okay. Anybody who wants to read this one? Anyone?
I can read.
Okay.
67-year-old man presents with a 2-week history of progressive dyspnea, orthopnea, and pedal edema. His history is significant for heavy smoking, that is 30 cigarettes per day for more than 40 years, a 20-pound weight loss over past 3 months, loss of appetite and weakness. His physical examination reveals pulse 130 per minute, blood pressure 105 by 90, paradoxic pulse, distant heart sounds, non-palpable cardiac impulse, slight dullness at both lung bases, and bilateral pedal edema. His chest X-ray shows enlarged cardiac cillates and a large pericardial effusion. They are confirmed by echocardiography. Acid-fast staining of the pericardial fluid is negative for acid-fast bacilli. CT scan reports are awaited. What is the most likely etiology of the pericardial effusion? Pulmonary tuberculosis, viral pericarditis, bacterial pericarditis, malignant pericardial effusion, or congestive heart failure.
So one said E, the other are saying E. Anybody else? Some are saying D. Anybody else who has a different opinion? E, D, D. Okay. E, D, D, D. Okay, let's go with the D. So somebody's saying D. A lot of you guys have been saying D. So the answer is malignant pericardial effusion. So what is the thing? The most likely etiology is the malignant pericardial effusion. Pericardial effusion is consistent with the 20% of the cancer patient. Cancer is most common because of the pericardial tamponade. So 16 to 41% the patient smoking, loss of appetite, weight loss, so having all those malignant symptoms. Along with this, having the tamponade. So lung and breast cancers are the most common involving the pericardium. Leukemia, lymphoma, sarcoma, and melanoma. So this thing. Cytology of the pericardial fluid and pericardial biopsy. So you can do further. So this is basically needs prompt treatment with the pericardiocentesis to relieve the increased and diastolic pressure and the inadequate ventricular filling. Congestive heart failure is characterized by the weakness, breathlessness, abdominal discomfort, edema in the lower portion of the body. Okay, so these things along with it. And somebody chose something else too. So just see it from here. Anybody who wants to read this one?
A 29-year-old woman is evaluated for a 3-day history of fever and pharyngitis. Medical history is significant for hyperthyroidism diagnosed 3 months ago. She consumes a vegetarian diet. Her only medication is methimazole. On physical examination, temperature is 38.2, 100.8. Other vital signs are normal. Posterior pharyngeal erythema is noted. Lab studies are hemoglobin 139, leukocyte 2.3, neutrophils 20%, lymphocytes 72%, monocytes 8%. Absolute neutrophil count 0.46, mean corpuscular volume 92, platelet count 302. Which of the following is the most likely diagnosis? A, cyclic neutropenia, B, vitamin B12 deficiency, C, drug-induced neutropenia. D, benign ethnic neutropenia.
Okay. So 2 said C. Anybody who else has a different opinion? So drug-induced neutropenia. So he has been taking methimazole. So might be agranulocytosis, right? So let's go with the C and see what the answer is. So the answer is C. Neutropenia is defined as a circulating absolute neutrophil count less than 1.5. Severe neutropenia is an A and C. So drug-induced neutropenia suggesting from the impairment of the normal granulopoiesis. Okay. Then thionamides, propylthiouracil, and methimazoles are among the drugs known to cause agranulocytosis. So overall prevalence is low. So agranulocytosis is the most likely to occur within first 3 months of the drug initiation and is most common in the woman and appears to be dose related with the methimazole. A and C should recover within 1 to 3 weeks after discontinuing the medication. So here, this is a very nice chart. It says A and C less than 1.5, then signs and symptoms of the severe illness, febrile, hypotension, and altered mental status. A and C, yes. Admit to the patient, give IV antibiotics. Is it a new onset? No. Then ethnic, benign, familial, or cyclic neutropenia. Then the infectious drug or the infectious exposure? Yes. Does resolve? Yes. Then drug or infectious related neutropenia. Then others, cytopenic? Yes. Bone marrow, biopsy and aspirate and follow cytometry. And then moving on to the next one, they will check folate, vitamin B12, normal. Then they will move on to this one. And if low, then megaloblastic anemia. So this is a whole, they might give you this thing. So on the basis of that, you can see what you can do further. So this is a very nice chart. Okay. So anybody who wants to read this one, this has 2 parts. So who is going to read both of them?
I can.
Okay, go ahead.
An 80-year-old man is evaluated for a weak history of poor appetite, myalgia, fatigue, arthralgia, and low-grade fever. He was previously healthy and active. His only medication is acetaminophen as needed. On physical examination, patient is afebrile. BP is 155 by 195 and pulse rate is 80 per minute. There are no orthostatic changes. There is trace of lower extremity. There is a trace of lower extremity edema. A faint red-blue reticular rash is present all over the lower extremity. Lab study shows hemoglobin 120, calcium 2.5, creatinine is not given. Creatinine current is 274. Baseline 2 months ago was 79.6. Urine analysis, blood 3+, protein 2+, dysmorphic and erythrocytes 20 to 30, leukocytes 5 to 10. Chest radiograph shows no acute infiltrates. Kidney ultrasound shows no masses or obstructions. Which of the following is the most likely diagnosis? A. Myeloma cast nephropathy. B. ANCA-associated glomerulonephritis. C. Proliferative lupus nephritis. D. Minimal change glomerulopathy. E. Antiglomerular basement membrane antibody disease.
So anybody has any opinion regarding that? D. Okay. D. So many of you been saying B and then one said D. Anybody else? Okay, let's go with the B. So B is the answer. The most likely ANC-associated glomerulonephritis. The patient's clinical picture suggests rapidly progressing glomerulonephritis. Steep rise in the stress serum creatinine. Hematuria, proteinuria, differential diagnosis might be RBGN, 3 immunofluorescence findings. So post-immune staining, linear staining, or granular staining. More than half on acute onset of flu-like symptoms. And then the lacy and the reticular rash on the examination is related to the ANCA-associated vasculitis. So it can be tested by the antiproteinase 3 and anti-myeloperoxidase ANCA antibodies. Undergo a kidney biopsy to confirm the diagnosis. This one.